Hey guys, so today we are going to be talking about knee x-rays. So let's get into it. So the different types of knee projections are AP, oblique, lateral, sunrise, and intercondylar fossa or tunnel views. There are a bunch of ways that you can do some of these exams, but we're going to keep it simple for time's sake, so let's talk about it. Our first projection is going to be an AP knee. These can either be done bilaterally, as you can see here, or they can be done one knee at a time, like you can see here. And for these exams, the SID is always 40. You're going to center 1.5 centimeters below the patellar apex, which on me is pointed out right here, and the patient's foot will be facing forward. And on myself, I would use 65 kbp at 4 mass, and this is what the x-ray looks like. And there are some notes up top about what to do about angles if the patient's pelvis is different sizes. For the oblique knee, basically the same thing as an AP, except we're going to intern the leg 15 degrees medially, perpendicular beam, basically all the same stuff, same centering point, pointed out right there, and that's pretty much, the whole shebang, same technique, same everything. The x-ray popping up is going to show the joint space between the tibia and the fibula. That's what the rotation of the leg was for. Moving on to lateral knees, since there's a 5 to 7 degree difference between your condyles, we put an angle on it. You center 2 inches below the patellar apex and to the mid-condylar area, and you're going to bend your leg 20 to 30 degrees to open up that joint space a little more. And I'll increase my mass to 6 for this one. Yeah. And here's the x-ray, ta-da! Look at those superimposed condyles, very nice. That's pretty much all you want from a lateral knee. Say hello to me, this is sunrise, and there's a couple different ways that you can do this, like this, and the next picture coming up. So there's a couple different ways that you can do this. The Lorne method was the first one I was doing, which is usually a perpendicular beam, sometimes 15 degrees caudal. Houston method was the second picture, and that's a 15-degree angle, and Merchant was the last one with a 60-degree angle. And here's the x-ray. We're going to do that at 3 mass. And tunnel views, yay. So you're just going to match the long axis of the lower leg with your beam. You're basically just centering to the back of the knee, which I kind of pointed out here. And this is the Camp Coventry method right here, which is pretty common. The one that I so gracefully demonstrated is the Rosenberg, which is popping up here. We're gonna move on. This is what the x-ray should look like. I would shoot this at 65 at 5 for those. Okay, patient care and education time. So the best way to gain patient cooperation is to explain the exam and the expectations, like what pictures you're going to take and what they will have to do and so on. Then also avoid causing injury by working with the patient. Some of these positions can be uncomfortable, so if your knee is genuinely hurt, do not force anything. Offer the patient a pillow or maybe some sponge for their ankle to increase comfort, and obviously always perform aid it, because that is important. For the equipment, you're going to need an x-ray tube with a fast image acquisition speed so that the patient is in those positions for the least amount of time. You will need a wall bucky or a free plate and a monitor that can properly display your images so that you can check the quality. Some of the exams can be done on a wall bucky, just make sure that it can go down far enough so that the whole knee is visualized. And some of these views are much easier with a free detector instead of the wall bucky like the sunrise or when you're doing pediatric patients. So, just be aware. And then we're going to go into image acquisition. So first the electrons are going to boil off the filament, causing thermionic emission. The acceleration happens because of the polarity between the cathode and the anode. Then the target interactions that are going to happen at the anode are either characteristic or Bremsstrahlung. Then X-rays will exit the tube and interact with the tissue in the knee. The IR will detect the X-rays and convert them into a signal using an ADC or analog to digital converter. And then the signal will be processed by the computer's algorithm and the image will pop up on your screen. Pretty basic stuff, nothing too special with knees, so that's pretty much that. And the best way to use Rad Bio and knee imaging is to spend the least amount of time exposing to get the best image that you can. Use the correct SID for distance and image quality so you can also shield the patient from the thighs up while you're taking knee x-rays, even though we don't really do that, but you can. Avoid repeat exams is also a great way to reduce exposure to the patient. So this is a little example of the shielding technique for knees, and also using proper collimation is really important to reducing dose. So some other considerations to keep in mind are that there is a potential for hardware or pathology. So knee replacements are very common, so you would need an increase in technical factors if the patient discloses that they have one. Also pathology, things like arthritis and gout do affect the attenuation of the beam and differential absorption, so just be aware of that. And that's about it, so I hope this was a good refresher. Thank you guys.